To see you all here in this small room, but well, I consider to bring in a patient in refractory shock here and to demonstrate how to treat them. But as you understand, that will be very difficult. So what I did, I have a slideshow on this topic, and I will talk mainly on norepinephrine and vasopressin. But of course, we can make it very interactive. So stop me anywhere you want. And we have half an hour to discuss this topic. So here you see my disclosures. And I do some work for ALP Pharma and also for Payon for angiotensin II. For both companies, we run in our hospital a registry with patients from all kinds of sites from the Netherlands and other countries in Europe. I'm an intensivist in the Netherlands. I work 4 days per week in the intensive care unit treating patients like you probably. And 1 day per week I'm a professor at Wageningen University. There my main focus is to study the role of nutrition. But I was very involved also in sepsis for years. So what I would like to do is to take you on a journey of what to do with patients with severe hypotension. Maybe when norepinephrine is not enough, what should you do then? And what is in the guidelines? And how can we manage the patient with maybe second vasopressors? What is the best way to do that? So this is me, and I have a PhD in antibiotics and infectious complications. So that was the reason that I came involved in the field of sepsis. I'm also the chair of the sepsis guideline program in the Netherlands. I was chair of the Surviving Sepsis campaign in the Netherlands. And I'm also chairing a congress every year in the Netherlands on sepsis with international speakers. And we have a new organization, it's called SepsisNet, to create awareness for sepsis, because in the Netherlands, the general public, the laypersons, don't know what sepsis is. And we feel that for the early recognition, it's important. But we are going to talk now about hypotension in septic situations, so-called septic shock. We have no new definitions for that. You're aware of that, the sepsis 3 criteria. And so now you need hypotension after adequate fluid resuscitation, and you need elevated lactate levels, and that's the definition for septic shock. So I will talk mainly about sepsis patients, so vasodilatory shock, distributive shock, and not about cardiogenic shock and other shock situations. And the main focus will be on what to do with the vasopressors. So the problem is, of course, you will give fluid therapy and you will give vasopressors to your patient. The most used vasopressor in Europe is norepinephrine. You use norepinephrine, noradrenaline in your unit? Yeah, it's the first line therapy. And we give it more early nowadays. Already during intubation or so, you start already, sometimes peripheral. It can be done for a short while, and then it's better to insert a central venous catheter, of course. But then we have the situation that you have the patient, you give a lot of fluids, and the norepinephrine levels go up, and the nurses say, well, I'm a little bit afraid this patient will die in the next few hours. What are we going to do? The levels go up and up. You have this kind of patients in your unit with all these high levels? So that's the group where we talk about here. So then we have this concept of refractory shock. But can anybody in the audience tell me what is refractory shock for you? What you would say is a patient with refractory shock? Anybody? Did you find some definition in the literature? I think there is not a real definition for that. It depends on what you feel that is a lot of norepinephrine. What is a high dose? So it's also dependent on the body weight. So sometimes you use the gamma or micrograms per kg per minute. You're aware of that. And what we feel in the Netherlands now, because I convened with a lot of colleagues of myself in the Netherlands during round table session and said, what is for you, what is a high dose? And some say 0.1, 0.25, 0.5, 1 gamma. That's really high. Now the problem is, if you give a second vasopressor to a patient with very high norepinephrine levels, the result will be that all the patients die, and you believe that giving this vasopressor is not helpful, the second one, because... So my nurses, for years we gave telepressin as a second vasopressor. We gave a bolus, then the patients turned pale and blue, and they died. And they said, don't use this drug because it's dangerous, all the patients die. Well, maybe that's the underlying disease, the severity of the septic shock, of course, but still, what is the best moment to start this? So we know that in this patient group with very high norepinephrine doses, mortality can be up to 60%. So it's a very high mortality group. So can we make a difference in this group? So in this group, in the literature, you see 40 to 80% mortality in series of this kind of patients. So, and we know that earlier start of norepinephrine is probably associated with a better outcome. So don't wait until the blood pressure is like 70/40 for a long time, because then you induce more organ dysfunction. So maybe you have to keep the blood pressure on a certain level and start early. So the early initiation of norepinephrine is beneficial. But what when the doses are so high, it's not enough? So what is in the guidelines? Let's look at the surviving sepsis guidelines. So there are many treatments for septic shock, and I've summarized some of these treatments here. You can use extracorporeal systems. Of course, you have to check whether your cardiac output is okay. You can have marked septic cardiomyopathy, and even in young patients, they can have heart failure. So in some patients, you need inotropes. And of course, you need fluid resuscitation for optimal, circulating volume. Some believe that you can use CVVH or ECMO or so, but we focus today on two, norepinephrine and vasopressin. So what can you do with that? Very simple vasopressor strategy in refractory shock. What was in the guidelines? This was 2015. They said, well, you can use adding vasopressin in patients not really stable on norepinephrine up to a dose of 0.03 units per minute. And if you use vasopressin, it's independent of the body weight. So you can use 0.01, 0.02, 0.03, 3 steps. And also in later guidelines, still it's recommended, leading to a recommendation as adjunctive therapy. So at this moment, we don't start with vasopressin. You always give first norepinephrine, and when you go to very high levels, then you add the second vasopressor. Now, how can you identify this kind of patients? Well, we discussed before, there's no real definition for refractory shock, and it is also dependent on the target. You know that there have been the sepsis PAM by Dr. Asfar, the study. What is the best target for blood pressure in sepsis? Should it be 80 millimeters or 65? And we know for most patients 65 is enough. But maybe for patients with previous hypertension and drugs for that, then you should go to a higher level. It's maybe not for all the medication, maybe for the ARBs and some other categories, but not for ACE inhibitors. And well, in the Netherlands, we take now 0.25 microgram per kg per minute as a high dose norepinephrine to consider giving a second vasopressor. Of course, you have to give fluids, because what will happen when you have your patient under-resuscitated and you start a second vasopressor or a high-dose norepinephrine? What will happen? What will you see probably in the patients? Anybody? You see problems of peripheral ischemia when you don't have the patient resuscitated, or maybe even a drop in cardiac output because the afterload of the heart is too much. So it's important to use optimal fluids. And how can we know whether the cardiac output is okay? Any ideas? How do you do it in your unit? How do you measure if the cardiac output is okay? Eh? Pico, yeah. You can insert a Pico device. Maybe if you are experienced, you can do ultrasound of the heart. Maybe you can see what is the contraction and the fluid status of the heart. You can also use maybe the mixed venous oxygen saturation. So there are different techniques, but I think if you want to start a second vasopressor, you have to do something with monitoring also the cardiac system. Is there really flow? It's always two things, pressure and flow. And this is focusing on pressure, but you have to be convinced that there is also flow. Otherwise, you will have more complications, like ischemia of the nose, ears, and the fingers and hands. And so you don't want it. So what we do, we start with 0.25, and we have a registry. We put all the patients in a registry from different centers, and I will show you some data on that. I go back here. What is interesting to see in the registry, the starting point of the norepinephrine doses to start the second vasopressor, vasopressin or argipressin, was 0.45. In our unit, we have a protocol. We will start at 0.25, but the actual starting was at 0.41. How is that possible? What is the explanation here, do you think? Now, patients in the refractory shock, they have increasing levels of norepinephrine. So the moment I think we have to start, I give the orders to the nurse, they have to prepare the medication, it takes time, and still the norepinephrine is going up and up. So when you make a protocol and you want to start at 0.5, you have to consider that they will probably start at 0.75. So the patient is more sick then. And we know that earlier start is probably better. So what are the benefits? Now, those patients with the highest doses of norepinephrine have the highest mortality. So norepinephrine kills you or not? No, those patients are more sick. But still, is norepinephrine always beneficial? But we know that there are harmful effects. So that's catecholamine overloading the patient, and that can lead to myocardial problems and also effects on the immune system. So we know that patients on high norepinephrine doses go more into an immune paralysis situation. So it's bad for the immune system. And if you compare with vasopressin, that doesn't have this effect on the immune system. So there's a difference between vasopressors and the effect on the immune system. So that could be a reason not to increase your norepinephrine dose, but to go for a second vasopressor. Okay. So this is endothelial muscle blood vessel muscle cells, and you can use norepinephrine, you can use vasopressin, or you can angiotensin too. That are the main vasopressors to do the job. Now we focus on vasopressin, and we know that in late phase of septic shock we see a lower level of vasopressin, suggesting that there is vasopressin deficiency. So it's not only a vasopressor, it's also a drug that counteracts a deficiency in the body. Okay. Now, how does it work? Vasopressin or argipressin is just the normal molecule we have in the body. So it has more actions. One is vasoconstriction via the V1 receptor. The other is water retention, but it's in lower dosage, the V2 receptor. And there's also a V3 or V1b receptor, and that's related to the release of ACTH. So it's also involved in this axis to produce endogenous corticosteroids, and that can be helpful also in septic shock, as you know. Now, there is this landmark paper by Dr. Russell from the New England Journal of Medicine studying vasopressors versus norepinephrine infusion in patients with septic shock. And you can see the survival is a little bit higher, but it was not significant in this study. It did not reduce the mortality. However, it was shown it reduced the dose of norepinephrine markedly. So when you start vasopressin, in most patients you see a drop in the need for norepinephrine. So norepinephrine sparing effect. And they also found in post hoc analysis of this study that if you take patient groups with a lower Apache 2 score or a lower lactate level, that the effect on outcome was better. So this suggests that you should not wait until you have very extreme high dosages of norm, but that you have to start maybe earlier with the second vasopressor. Or maybe, as some authors advocate, maybe we have to start with 2 or 3 vasopressors like we do in antibiotics, and then taper one of them over time. I would not suggest that, but maybe when your norepinephrine levels are over 0.25 or so, you should consider maybe a second vasopressor. That could be helpful. And there are meta-analyses on the studies. It has been shown that new onset atrial fibrillation is lower when you use a second vasopressor like vasopressin. And also there is a signal of lower mortality, but well, not in all studies, it's a slightly lower mortality. And there are more studies. This is the Vanish Trial, and in this study they found a signal for an effect on the renal function. So a better renal outcome, so less renal replacement therapy and that kind of intervention. So that's helpful. So there is a trend towards less renal replacement therapy in distributive shock when you add vasopressin. There is a little bit more digital ischemia, but I told you that we do a registry in the Netherlands, and in the Netherlands we found it was very rare. And one of the problems is, I already told you, if you not have optimally resuscitated your patients and your cardiac output is not optimal, you see more ischemia. So I think the majority of this can be prevented, and of course you also have to balance whether you want to have some digital ischemia and save your patient, or let the patient die during refractory shock. That's because it's a severe high mortality risk situation. And if you see the meta-analysis, there are some benefits on atrial fibrillation, maybe on mortality and for AKI and renal replacement therapy. And so this is another meta-analysis clearly showing this effect. What also is important with the study that lower acuity patients, so when you have lower Apache 2 and lower lactate, benefit from the addition of vasopressin, is also shown in this study, and this is the timing. So when you start vasopressin within 3 hours of starting norepinephrine, you see a better effect on outcome. So don't wait until the patient is in severe refractory shock. You have to start it earlier to see a better effect on outcome. This is the result of this study. So this is the protocol we use in our unit, and I can lead you through it. So you only have 3 dosages of argipressin. So you have the patient, and the mean arterial pressure is not enough. After resuscitation, the cardiac output is okay. Then we start when the norepinephrine is at 0.25. And then we start at 0.1 international units per minute. You increase every 15 to 20 minutes until you have a good blood pressure. And you have these 3 steps. It's done in a perfuser, so it's very simple administration. And when it's okay, you lower the norepinephrine. And it's important not to stop the argipressin when you're back at 0.25, because then you will see rebound hypotension. I will show that later. So we go back to 0.10, a very low level. And maybe the literature tells you you should first stop the norepinephrine and then the vasopressin. However, we have some patients that have sedation with propofol, and you're all aware you have these patients, they need a little bit of norepinephrine, probably for the sedation. And is that really necessary to give vasopressin? Because it's a little bit more expensive than norepinephrine. So what we do, we taper until 0.10, so a very low norepinephrine dose, and then we try to reduce the vasopressin. When the blood pressure drops, of course you can go back up with your vasopressin. When it stays stable, and that's in most of the patients, you further taper the artepressin until you've completely stopped the vasopressin, and then of course you continue to reduce the norepinephrine. But not stop it at a very high norepinephrine doses, because for them you will see rebound hypertension. And that's also in this meta-analysis what you should do first. Stop with the norepinephrine or the vasopressin, and when you stop the vasopressin first, you see more hypotension. So it's important to taper the norepinephrine to a very low level. So these are preliminary results from our registry, and you see the moment we start the artepressin, we can reduce the norepinephrine doses, and you see also this kind of belly, this shape. So it seems that the effect of the vasopressor activity of vasopressin is more pronounced even, and that could be due to that you solve also the vasopressin deficiency. So it's acting in two ways. You solve the vasopressin deficiency problem, and of course it's also a vasopressor. And here you see what happens if you stop too early with the norepinephrine, you need more. So you see the rebound phenomenon here. So this was from the early days in the registry, and now we taper to a lower norepinephrine dose. That's important. And what are responders? Well, you need some kind of definition. What is a responder to vasopressin? We use when the norepinephrine should not be increased any longer, but stay stable, or can be reduced within 2 or 3 hours after the start of vasopressin. We call that responders. And this is the initial data. We had like 1/4 of non-responders. Now it's only 20%. So 4 out of 5 patients in the registry show an excellent response with a reduction of norepinephrine. So it's very helpful. The mean duration of the vasopressors was 30 hours. So slightly more than 1 day, and then you can already stop it. So it's just for a short while. And also with respect to costs, that's, I think, acceptable to do. So what about non-responders and responders? We did all kinds of analysis, and well, there's not really a big difference between the starting dose of norepinephrine. You see 0.4, 0.5. We see there is a slight difference in the obese patients, and we're working on that because it seems that the non-responders have a little bit higher BMI. And that's important because there are some papers suggesting that it should not matter whether the patient has a high or low BMI, because it's independent of body weight, the dosing of this product. But we're working on that. Maybe for obese patients you should add another additional step of 0.04. Maybe an additional step could be helpful, but it was not tested here. So there's no difference in all kinds of sepsis background, so it works as good in any sepsis cause. What we found that was significant difference between the responders and non-responders is that the non-responders already had lower blood pressure. So this may suggest that they are more deep into the refractory shock already, also suggesting do not wait too long before you add the second vasopressor. And what you see, this is 2 hours after the start, that in the responders you see that the norepinephrine dose has dropped, and it's even a little bit higher in the non-responders. So that's typical. Non-responders, within 2-3 hours you see that the norepinephrine doses go up, and maybe then you have to consider even to stop it. If it doesn't help, you maybe can stop it. We see in the database that most physicians dare not to stop it. They continue it because they feel, what happens when I stop it? Maybe it drops more, but that's always the problem here. But the responders show a very good effect. Also, the blood pressure is higher after a few hours in the responders. And we see also that the non-responders show increase in lactate levels, while the responders show a marked decrease in lactate levels. That can also be due to the effect of catecholamines on this difficult step of pyruvate to acetyl-CoA. There you have the catecholamines can also shift pyruvate to lactate. So that doesn't per se not mean that there is anaerobic metabolism in cells. So that can be due to the effect of the catecholamines. So the other variables are rather similar. And you see that also the dosages of norepinephrine is lower, the blood pressure is higher, and also the heart rate is lower. And we know if you see studies with vasopressors or interventions, those interventions that increase the heart rate show negative outcomes. That's the reason why we don't use epinephrine because it increased the heart rate. It's not very good in septic shock. But you see that vasopressin also lowers the heart rate in these patients. They are all having tachycardia, which is typical for refractory shock patients. So the outcomes are rather similar, but I think the numbers are too low yet. When we have the final results, I will show you, of course, also the outcomes. There is maybe a trend. If you see that in the responders, the mortality is always a little bit lower, but it's non-significant with these numbers we have here. And we also found that non-responders during the therapy show more atrial fibrillation. That's according also what the literature has shown. And we tried to find what is the optimum for the response rate. And you see the average response rate, non-response rate is now 22%. So 4 out of 5 patients have an optimal response to vasopressin addition. And these are the dosages, the starting dosages of the moment of norepinephrine. So how high was the nor at the moment you started the vasopressin? There's not a clear clue here, but it seems the higher the norepinephrine, the more likely that you will see an effect. But if you want to see a change in outcome, you have to start earlier. That's important. So the take-home messages: high-dose noradrenaline monotherapy may not be the best. I've shown you there is an effect on, well, the heart and the immune system. Vasopressin addition has catecholamine sparing effects. You can reduce your norepinephrine in 4 out of 5 patients. It may reduce atrial fibrillation, the incidence of AKI, and the need for renal replacement therapy, and possibly mortality. I've shown you our protocol. You can send me an email. I can send it, or if you want to participate in the registry. Well, non-response we have defined as an increase in norepinephrine within 2 hours after the start of vasopressin. And the response is very high in many patients. And well, recent studies suggested that irrespective of the norepinephrine dose, maybe you have to add it within 3 hours in all your patients. Now, we have to see more data about that, but it's a challenging concept. It's a multimodal vasopressor therapy. That could be the future, and maybe even a combination with angiotensin II in the future. So, and after 2 hours, we see that the non-responders have higher lactate levels than the responders, and also develop more frequent new onset atrial fibrillation. And in the registry, we found a low incidence of serious adverse effects. So we think it has an acceptable safety profile, and I told you that probably the complications are very much related to the amount of volume resuscitation and whether you checked your cardiac output, if there is enough flow in the patient. So with that, I'd like to conclude. Maybe there's time for a few questions, but I don't know if we have to stop. Yes, please.
Why don't you start the vasopressin up to 0.03 immediately and win the NORAD instead of going 0.1, 0.01?
Yeah, the question is why not start at the highest dose? Because it's not necessary in many patients. Some patients have an excellent response on 0.01. And then it's, of course, for costs. And maybe you don't want to have too high blood pressures. You don't want to induce too much of vasoconstriction. So if you see a response on 0.01, and we see that in some patients, we already start to taper the norepinephrine. But in, I think, 2 out of 3 patients, you go gradually to the step of the highest dose. Yeah, it's more common. Yes, please.
How do you taper the doses? Do you taper both together, or you taper off the vasopressin first?
No. So you start vasopressin, and then it's of a certain level, and then we keep it on that level, and then we start reducing norepinephrine. We go down, and when it's at 0.10, then we will start the vasopressin. If you start the vasopressin too early, you see that the norepinephrine has to go up markedly again. So that's the rebound hypotension phenomenon. So keep it on the high level or the level where you came from, because when you go from 0.1 to 0.2 and you see the effect, you don't have to increase the vasopressin, you keep it on that level, and then you start to taper the norepinephrine. And in some patients, you can have in 6 hours that you are back at 0.1. So you see a lot of effect. And my nurses now, they ask me, can we start with vasopressin? So at first they said, don't use terlipressin because all the patients die. And so this has changed our practice completely, because we see now 4 out of 5 patients come out of the refractory shock and feels much better. Of course, still a lot of patients die in this condition because they're very sick, but at least when you see this kind of effect, you get enthusiastic. Yeah. No. Yeah, the question is whether we should measure vasopressin before we start the therapy. It's difficult to, I don't know if there is a point of care test for that. I don't think so. So, and second, when the levels are not low and you give vasopressin as it is a vasoconstrictor, in many patients you still will see an effect. Maybe not to solve the vasopressin deficiency, but it's also a vasopressor. So I would suggest just to start it at a certain level of norepinephrine. Make your own protocol and take a threshold and try to start with it in this way. Yes.
Patients with cirrhosis and septic shock, your second vasopressor of choice is terlipressin or
Yeah, the question is about a patient with a liver disease. In the protocols for hepatorenal syndrome, and so there's still terlipressin, but you can also use vasopressin. And I think terlipressin has a long half-life, and it can accumulate. But there is more literature in this specific group, but it's only in hepatorenal syndrome. So we also use vasopressin because it's more titratable. It's the half-life is shorter, and you can manage it better. So especially if you give terlipressin as a bolus, you have a huge effect. But when you use it as a continuous infusion, it can accumulate because it has a long half-life. Yeah.